Hello, hey. As requested, I wanted to go over the rest of the cardiovascular emergencies study guide for you. I already did a video on this anatomy review, so next we're going to start with the pharmacology review. So the action and doses of aspirin. So how does the aspirin work in preventing an MI? It inhibits platelet aggregation. So it makes the platelets less sticky. And that way, when the patient has a ruptured clot and the coronary artery has a plaque and they have a ruptured plaque and a clot starts to form, it can help by making the platelets less sticky. Nitroglycerin. Nitroglycerin. So the action of nitroglycerin is it dilates coronary blood vessels. So why do we want to dilate coronary blood vessels? Well, in on myocardial infarction, if we have a let's see, here's our artery here. We have our blocked artery. We can't really get this plaque off and unblock it. Usually there's a plaque that's ruptured here and we build a clot. But if we dilate the artery over here, we can increase some of the perfusion. So remember, in a myocardial infarction, the problem is the muscle doesn't have enough, the muscle's damaged. The muscle doesn't get enough blood, oxygen, nutrients. So if we dilate the artery, then possibly we can deliver a little bit more oxygen and nutrients to the cells. Side effects of nitroglycerin. Hypotension. That's why it's a contraindication. Here is hypotension. We can expect a drop in the blood pressure when we give nitroglycerin. So if the systolic blood pressure is less than 100 and we give nitroglycerin, it's going to drop even further. Side effects is hypotension, headache, and the contraindications is hypotension and then ED drugs within 24 hours. Okay, cardiogenic shock. So we talked about all the different shocks, but this is cardiogenic shock. There's a bad pump, so very weak pump. So what are our symptoms? Progressive hypotension. So the heart isn't pumping, so if it's not pushing out enough blood, our blood pressure is going to drop. And the heart rate can be, it can be high, but that's like the heart wants to compensate and increase the rate of the heart, but a weak, bad pumping heart can't always respond. So the heart is going to the body's going to try to make the heart beat faster, but the weak, sick heart can't respond. And a lot of these patients are on beta blockers, calcium channel blockers that are preventing the heart from increasing the rate. So the rate is really plus minus. So hypotension, and then pale, and they could be diaphoretic. And then really we could see symptoms of congestive heart failure. So we've got a bad, weak pump, so we can back up fluid into the lungs and have pulmonary edema, crackles, fluid in the lungs, shortness of breath, or we could get, if it's on the right side, we could get JVD. And then again, the blood pressure is progressive. Position the patient supine. We always want, in shock, we always want to position the patient supine. That's part of our shock treatment. But most of these patients can't tolerate it. So if they're lightheaded and they can't tolerate it, it's position of comfort, which is probably semi-Fowler's. Aortic dissection. So this is when the aorta, there's a tear in the aorta or rupture. So the symptom is a tearing pain. And if it's in the abdominal aorta, it would be tearing abdominal pain. If it's in the chest, it could be a tearing pain. But when you're reviewing for an exam, what you're looking for in this scenario, when you see the patient experiences a tearing pain, then you're going to think a dissection. Okay, congestive heart failure, left versus right. So I'm going to go with specifically right. Right-sided heart failure is going to be JVD, so jugular venous distension, and then just swelling and fluid retention. And left, we are looking at, this is the backup into the lungs. So we're looking at pulmonary edema, rales or crackles in the lungs, shortness of breath, hypoxia. And then really all we're looking at lower extremity edema, orthopnea. Remember the shortness of breath when you lay them flat. And then shortness of breath, difficulty breathing, fatigue. Angina, stable versus unstable. So stable is when the patient does have coronary artery disease. They have a narrowing of their coronary arteries. And when they're sitting and resting in a recliner, the coronary arteries are able to perfuse and give all of the heart muscle adequate oxygen and nutrients. But if they try to move around, like mow the lawn or walk a lot outside, the heart muscle needs to beat faster and harder to keep up with the demand. And that narrowing is going to prevent the right amount of nutrients from being delivered. When the heart doesn't get enough oxygen, it sends signal to the brain, remember, that says pain, pain, pain. And that's why you have chest pain. I do have this, here's a diagram here. We've got a clear coronary artery. Here we've got a coronary artery with some plaque. So this is restrictive. So this patient may be fine when they're sitting in a recliner resting, but if they get up and they try to walk or mow the lawn, because of this narrowing, the oxygen can't be delivered to the heart when the heart needs more. And so the brain is going to send a signal to the brain saying pain. And that's angina. And then here's our myocardial infarction. Okay, so stable is the pain is relieved by rest or nitroglycerin. And unstable, pain is not relieved. I'm going to abbreviate nitroglycerin to NTG. Okay, hypertensive crisis. What is considered a hypertensive crisis? A systolic blood pressure greater than 180. Chronic hypertension is greater than 140/90. And okay, so the symptoms of an MI. So that's the acute coronary syndrome. Acute coronary syndrome is the constellation of symptoms of an acute MI. Here's my symptoms diagram right here. So the pain. Okay, so this is of course the classic pain. Remember, there's also anginal equivalents, but the heart muscle isn't getting enough oxygen, sends a signal to the brain, pain, pain, pain. So where's the pain? It could be in the chest. Sometimes patients would classically say like a squeezing or an elephant sitting on my chest. There's also it could radiate to either the right shoulder or the left shoulder. It could radiate to the neck, the jaw, or the back. And then sometimes people have symptoms that is nausea or indigestion. They think it's indigestion. Maybe they take some Tums, it doesn't go away. It's really, those are symptoms of a myocardial infarction. Fatigue, sleep disturbance, especially right before they actually have a myocardial infarction. That's what prodrome means. Headaches and dizziness. Remember, a lot of people don't necessarily have classic chest pain. They have an equivalent of the angina, which could be weakness, sweaty, don't feel good, pale, headache and dizziness. Shortness of breath. This is a really big anginal equivalent. It's the equivalent of pain in the chest. And then anxiety, feelings of doom. This is why if somebody says, I feel like I'm going to die, we don't say, oh, don't worry, you're fine. We just we say we're doing everything we can to help you. But remember that sometimes before people have a big, massive MI, they say that they have feelings of doom. It's a symptom of a myocardial infarction. Okay, so those are the symptoms. When do you give O2? So if the patient has SATs less than 94. And we are going to give right here 4 liters nasal cannula for chest pain. Now, if it's a patient who's severely hypoxic, like let's say there's really profound cyanosis where they're blue all over, not just blue in the lips, and we're going to go with more than 4 liters nasal cannula. We're going to go with a non-rebreather mask. And of course, in all of your scenarios, remember, do not forget the basics, which is what are the indications of positive pressure ventilation? So rate less than 8, greater than 28, agonal, profound cyanosis, the ventilator's not working. Can't think of all the rest of them. Okay. All right. So these are the BLS. I've already done the BLS review for also. So I won't go through these, but I went over how fast the minimal interruptions are most important. The upstroke is critical. You want to have a good recoil so the heart can fill. We always follow what the AED says, even if the scenario is telling you, like the AED says you've shocked 7 times, it wants you to shock again. What do? You listen to the AED. Don't go down a road if maybe the AED is broken or anything like that. That's always wrong. What rhythms does the AED shock? VFib and VTAC. It does not shock PEA. What is PEA? That's when you have an organized electrical rhythm. So you have a PQRS complex. It looks perfect on the monitor, but there's no heart rate. And the AED does not shock that. Struck by lightning. So we talked about this in our environmental lecture, but the electricity follows the path of least resistance, which is along blood vessels and nerves. So we can expect that if it's following along the blood vessels and it goes through the heart, it could damage our pacemaker cells. So we can expect an abnormal pulse or arrhythmias. Start compressions right away. First thing you want to do is move the patient to a hard surface. Next thing you want to do is start compressions and also put on the AED. Those are really 1, 2, 3. Although they can be done simultaneously, or with a partner could do one, you could do the other. If you're looking at the absolute steps in order, you can't start compressions till they're on a hard surface. So hard surface, compressions, AED. We don't again say everything's going to be okay, because impending doom is a symptom of acute coronary syndrome and it can be felt just before an arrest. So the appropriate answer is we're doing everything we can to take care of you. We're going to get you to the hospital as soon as possible. If the blood pressure is less than 100 systolic, we do not give nitroglycerin. That's a contraindication. If we establish